and now we're going to hear, before the next Q&A, we're going to hear from Dr. Jonathan Wall at the University of Tennessee. Let's see, you always see the kitchen wallpaper, right? Very good, Dr. Wall. Okay, take it away.
Thank you, Muriel. I think my wallpaper is more famous than anything I've ever done in the lab. So I am going to give an update on the imaging study that we're doing with a peptide for systemic amyloidosis. And Muriel asked me to give an update specifically on the TTR patients as we've enrolled a few more than the last time I spoke to everyone. So by way of disclosure, we have NIH funding. I'm the scientific founder of originally a university startup called Solex that changed its name to Aurora and is now Atralis. And we have patent rights. I will discuss imaging data from what is now a phase 1/2 trial. And they are the available data to date. And this is not an approved imaging agent. I'm not an MD, so everything I say can be taken with a grain of salt. First thing, I want to thank all the patients who've traveled to Knoxville to participate, and Muriel for rounding up many of them to be part of the trial. Especially during these exceptional times. We've had remarkable response from patients with TTR over the last 3 months coming to Knoxville. And without their support and encouragement for what we do, we couldn't be doing what we are at the university right now. And we look forward to seeing them again. So as Dr. Castagno mentioned, TTR amyloidosis is associated with the heart, the nerve, and the GI tract most commonly, but also the eyes and the bladder can be involved. Historically, there were 2 types of TTR amyloidosis, polyneuropathy and cardiomyopathy, and they were considered to be mutually exclusive for many years. And now I think we're all learning that that's not the case. This is a multi-organ disease, and there's value, we think, in being able to image the distribution of amyloid for lots of reasons. One, because it can help with diagnosis and prognosis, and also because if these deposits can be quantified, then they can be used to monitor responses to therapy that everyone else has been talking about, these exciting therapies that are coming out and are out right now. So what I'll talk about, what I'll update is this first in human trial that we're doing at the University of Tennessee. I'll also say that this is not industry sponsored. We get support by donations to our program to conduct this trial, and I'm very fortunate to have an incredible team of people at the University Medical Center who allow us to do this in an efficient way. So many years ago, we developed an antibody for the treatment of AL amyloidosis, came out of our lab in Knoxville. And we did a study in patients with AL amyloidosis where we made the antibody radioactive to answer the question whether it could bind to amyloid deposits specifically in AL patients. And the trial was very successful. The antibody moved on to clinical trials. But we realized at that point that it wasn't going to be a perfect amyloid imaging agent because of the data we generated. And so we started working many years ago on a way to detect amyloid in patients. And we wanted an agent that would detect all types of amyloid, not be specific for AL or TTR, but be a generic amyloid imaging agent. We came up with this peptide that we creatively called P5+14, and that's the helical this is the peptide up here. This is a representation of it. And what makes it special is that it has very high number of positive charges along one side of this helix. And the other thing that allows this peptide to do what it does is that amyloid, the fibrils, and some of the proteins and sugar molecules that are in amyloid deposits are very negatively charged. And because you have a high negative charge in the amyloid and a high positive charge on the peptide, when you inject the peptide into the patients, it finds the amyloid. And because it's radioactive, that allows you to generate images of where the peptide is. And by extension, we think the amount of amyloid and where it is in the body. So this is the trial as it stands right now in part 1, which began in November 2018. The FDA required us to do the first 3 patients with AL amyloid multisystem disorders, and they were given radioactive P5+14, and we evaluated that for safety and to calculate the amount of radiation, the dosimetry that we were giving to patients before we moved on. These patients were imaged 7 times over 48 hours, and that was the data that allowed us to calculate the radiation dose. We're now in part 2, which we expanded during the summer of this year. We applied to the FDA to add more imaging slots. And so now we have the opportunity to study 85 subjects, actually. So 30 patients with AL, and we've imaged 19 to date, 20 patients with ATTR, and we've done 17. As I say, in the last 3 months, the patients with TTR have been remarkably brave and come to Knoxville to help us out. In that cohort, we've done 4 wild-type TTRs, 5 with the T60A, and as Muriel said, we haven't added on that annoying 20 to all these mutations. We've done 4 patients with L58H, one with, and some other sort of single mutations as well. Let me go back. We've done 2 of the 5 LEC2 image patients we've imaged, and we have this slot for other rare hereditary forms as well as localized forms of amyloid, and we've done a localized AL, ALICE, AGL, and APOA1. Again, the goal of this trial is to demonstrate obviously the safety of the reagent, but also the efficacy in terms of being able to image all types of amyloid. And then try and there are some secondary outcomes or measurements that we're making where we're trying to learn more about the disease and how this imaging agent can be used as a tool to help patient management. We are now able to enroll 5 healthy subjects, which will start next year. We've also added slots for 10 TTR mutation carriers who are asymptomatic. And we've also got permission now to do repeat imaging of patients who were positive and had their scan at least 1 year prior. Each patient receives a low dose of peptide and a low dose of radioactivity, just sufficient to generate good images. We image the patients 5 hours post-injection, and we do that because we wait for the peptide that's not bound to amyloid to clear from the blood, and that gives us better images. And as I say, the study is determined to assess safety and get some efficacy data on whether we can image organs that are known to contain amyloid, but also those that the physicians don't know. So this is a summary of the data for our TTR patients. This is a busy slide, and everyone says, oh, you don't have to pay attention to any of it, but I think everyone should pay absolute attention to everything here. And so what we've learned, so I've color-coded the patients. So the blue are the T60As, yellow is L58H, the greens are wild type, and then the ones with a single mutation where we've just done 1 patient are in white. And we've learned quite a bit just from this table. So one thing we noticed very early on is that we see positive cardiac uptake of the peptide in the vast majority of the patients we image, regardless of whether they were diagnosed with peripheral neuropathy or cardiomyopathy. So this is the diagnosis that was in the medical record. Some have combined, but many are single. But in most cases, we saw cardiac uptake of the radio tracer. We also find in several cases, the PYP scanning was done in many patients, but not all. Some patients we didn't know from the record whether it actually occurred. And in many cases, there were negative patients who proved negative in our imaging with our imaging agent, but also those where we had negative PYP scans with positive imaging of the heart. And I'll show what these images look like. The treatments that were being taken when we collected the data before we did the imaging, as you can see, most of the patients were actually taking diflunisal, a few taking tafamidis, and then few patients taking both diflunisal and Onpattro or Tegsedi. And so I'll go through and summarize that. So this is a very small cohort of patients, but it raises some interesting ideas that we can follow up in further studies. And so 50% of the TTR wild type patients had very little or no cardiac uptake. And I know it's only 4 patients right now, but those are the data that we've got. What we found is the patients with variant TTR, sort of the mutations, were much more eager to be recruited and contact us. We didn't go out to recruit wild type patients specifically. All TTR patients were available. And so we got a lot bigger response from the ATTR variant patients. 2/3 of the patients diagnosed with polyneuropathy had positive peptide uptake in the heart, which is interesting. 80% of the patients with absolutely normal NT-proBNP, and this is an enzyme, a serum marker that's indicative of cardiac involvement in amyloidosis, certainly in AL and TTR. And so this number that is calculated from a serum measurement is indicative of heart failure associated with, or heart involvement of amyloid in these populations. And we found that in patients with absolutely normal NT-proBNP, 80% of them had positive uptake in the heart. In 60% of the patients who had negative or ambiguous PYP scans, we were able to see P5+14 uptake. In the 3 patients who had positive PYP scans, each one of them was positive by our tracer, which was very gratifying. And in 85% of the patients taking flunitrazole, Onpattro, or Tegsedi, which is for polyneuropathy, they also had positive uptake in the heart. And cardiac amyloid sensitivity, which we are basing on if you have a known elevated NT-proBNP or a positive TET-PYP. We had 9 of those patients, and each one of those patients was positive with our imaging agent as well. So what does negative look like? And this is important because that'll help us see what actually positive looks like as well. So this is a patient who was diagnosed with wild-type ATTR based on a Congo red positive sample obtained after a laminectomy. And she visited us, and we injected the radio tracer. So on the left, you can see the CT scan, and here's the heart. This is the liver. And you can see in the PET scan, this is the radioactivity. There's no evidence of uptake at all in the heart of this patient. This large area on the right is the stomach, which is we see in every patient. This is normal radioactivity background. And then the large area at the bottom is the bladder. And that's the urine where the radioactive peptide that isn't bound to amyloid is being cleared. And so no evidence of heart whatsoever. And if we look at the axial slice, which is a slice across the body, that type of image, again, you can see the CT. This is the heart, and these are the lungs. And you can see very diffuse uptake, which is just radioactivity circulating in the blood at 5 hours post-injection. So this is what a negative scan looks like. And every other organ is absolutely clear as well. In contrast, in this wild-type TTR patient, this is more characteristic of what everyone expects to see. So again, the CT on the left, you can see the heart, and in the PET scan, you can see this characteristic sort of horseshoe pattern where the heart is the radioactivity uptake associated with the amyloid. This is the left side of the heart, the left ventricle, which is the thickest wall of the heart, and then you see this large horseshoe uptake. And again, if you look in the axial slice, you can see this, again, characteristic horseshoe shape that's associated with amyloid in the left side of the heart. And again, you can see a couple of images, whole body images where I've actually fused the PET, the radioactivity data, with the CT data. And again, you can see activity in the heart, very well defined. And in this patient, there was evidence also in the lumbar spine of uptake of radioactivity, which I've pointed out here as well, which is something we see in quite a lot of the TTR patients, is the lumbar spine region being positive. Now, this is a less characteristic, perhaps, wild-type TTR patient. Again, we see cardiac uptake in the heart. In this case, it has it in the left ventricular wall and the right side of the heart as well, which is very evident. This patient also had dramatic uptake in the right shoulder, which was much stronger than the left shoulder, indicating that there may be amyloid associated selectively with that joint. And in the left hand, you can see in the bottom here, the 2 spots, which I've sort of blown up, and you can see a little bit better. You can see very focal uptake around the thumb joint, or I wouldn't know how to describe that anatomically, but around the thumb in this patient, which wasn't evident, as you can see in the other hand. So this again might be very specific for amyloid in this region of the hand. This patient also had very dramatic accumulation of the peptide in the lumbar spine, which is also a site of known amyloidosis in TTR patients. This is a variant TTR patient, which is a patient who came to us with ocular amyloidosis, but otherwise had no other symptoms. And we generated a remarkable image from this patient. So what we see on the top left is very extensive accumulation in the region that was defined by brown fat around the neck. And we think that might be amyloid associated with brown fat. This patient also had both the left and right ventricle of the heart involved, as you can see in both the axial and the coronal slices. The patient's kidneys were also not negative. There was higher activity than we would expect for a negative organ there. And in this patient, which was quite remarkable, we saw the choroid plexus in the brain. The choroid plexus, as people have mentioned, is a site where TTR is made. It's outside the brain, but it contributes the TTR to the brain, and it also makes the fluid that bathes the brain and keeps it safe. But the choroid plexus was very evident in this patient, and the pancreas. In fact, the pancreas was the organ that had the most uptake of radiotracer, and we've not seen that in any other TTR patient that we've imaged to date. And you can see in the large image on the right here, this region of high activity, the bright yellow, is the uptake of the radiotracer in the pancreas, which we can attribute based on what we think we know as being TTR amyloid in the pancreas. And what the clinical manifestations, what that means for the patient, we don't know at all. But it was a remarkably multi-organ involvement of the amyloid in this patient, and very different from any other patient we've seen before. These are 3 images from patients that were diagnosed with, I can't see the top there, I think that's cardiomyopathy, and you can see the heart in all 3 of these patients being illuminated by the peptide, the left side of the heart as well as the right side of the heart. These large blobs below that is the stomach, and that's absolutely natural. We see that in everybody. And then the urine in the bladder is at the bottom there, and that's normal in everybody. This is a patient. These are 2 patients that were diagnosed purely with polyneuropathy, no evidence of any cardiac involvement whatsoever. But indeed, upon imaging with the peptide, we were able to see cardiac uptake in both these patients. And these are patients that both had normal NT-proBNP. And so this amyloid is what we would call preclinical or asymptomatic. It's not causing any sort of changes in serum biomarkers or function of the heart, but the heart actually has significant amounts of amyloid in it at this stage. Whether this will progress to be clinically important or not, we can't decide, but we'll hopefully follow these patients forward in the next couple of years. So one of the questions we've asked ourselves based on the imaging that we performed is there a disease-specific biodistribution in patients with AL and TTR? And the reason we asked this was because in addition to the peptide being able to say, yes, you have amyloid, or yes, there is amyloid, or no, there isn't, which we think will really help with the early diagnosis of the disease, does the distribution of amyloid in TTR and AL allow us in a single scan to perhaps differentiate the 2 disorders? And we think because of what we can see with the peptide, so the 2 patients on the left have AL amyloidosis, and what you'll notice is a lot of organs are involved. So in the patient on the left, the liver is involved, the spleen, the kidneys, the heart, and the bone marrow. In the second patient, you see again, liver, spleen, heart, kidneys, bone marrow. But in patients with TTR, generally, spleen, liver, and kidneys are not that involved. And the heart is the major uptake in all cases, other than the sort of physiological background we see in the stomach and the bladder. And so we've come up with a way of a very simple technique to come up with a quantitative measure. So we quantify one organ and a couple of other organs, and with quite high precision, we're able to tell from a single scan whether the patient likely has AL or likely has ATTR. So that's another function of the peptide imaging that we're looking into. So what have we learned so far from the trial? So the peptide is capable of detecting ATTRV, at least 6 mutations that we've looked at so far, as well as wild-type ATTR. The amyloid load can be estimated in multiple organs. These images can be quantified. So there's a very simple technique for taking the images, drawing regions on them, and coming up with a number that represents how much peptide is there. And we think that represents also how much amyloid is there. Imaging ATTR with a peptide has revealed complex extracardiac patterns of involvement. So in addition to neuropathy and cardiomyopathy, there's also amyloid deposited in sites that aren't clinically relevant or may become clinically relevant. We have to now we can get to this level of detection of amyloid in patients. It'll be interesting to see whether these extracardiac deposits actually have any clinical sequelae, whether they have any meaning. Imaging TTR with a peptide can visualize cardiac amyloid in patients with no symptoms, so they're asymptomatic, or with negative PYP scans. I think we've shown that certainly in our small cohort. Amyloid imaging with a peptide, as I say, as a surrogate for amyloid load. We're using that to assess the correlation between biomarkers, as I say, the NT-proBNP with amyloid load, and see how the amyloid load that we can image can be sort of quantified, or if there is a relationship with the NT-proBNP that everybody uses in the clinic. And as I mentioned, we've been developing a tool or a technique to differentiate TTR from AL with very high sensitivity and specificity that we hope might change the diagnostic algorithm. So a single scan with a peptide could provide, as I say, a yes/no answer, provide a quantitative distribution that can be monitored across time, and might, with some degree of accuracy, predict AL versus a TTR. I don't sit here in my kitchen all the time, although Muriel might think I do. I actually have a lab and lots of incredible people who work in it, and I want to thank them and the team at the UT Medical Center who help us do the imaging, and of course, all the patients who visited us and made all this possible. And with that, I will thank you and turn it back to Muriel.
Thank you so much. That was perfect. It really explained to everyone that just because you don't think you have cardiac involvement, that maybe it isn't two diseases, FAP and FAC. Maybe it's just one called ATTRV. And I think you've shown that with the scanning, and I think that's wonderful. And it's really appreciated, all the hard work you're doing. While I've got you here, are you taking appointments for next year? Can these people contact you? How can they do that?
So as I mentioned, as you saw, we have 20 slots for TTR in the current version of the trial, which we can expand, and we intend to. We've done 17. We have 2 slated to come in the new year, and so really we only need 1 more TTR to fill the cohort before we expand it further, which I think, based on the data, we will, because there are more questions to ask and more things to learn, certainly in both groups, both the wild type and the variant.
Can they get on a waiting list if they're interested? Can they tell you so that they can be on a waiting list?
Anybody can contact us, and they will talk to me or Emily, Dr. Martin, who's my colleague, who interacts with the patients way more efficiently than I do. And we would certainly love to hear about anybody. So if things grow and we expand these trials, then yeah, we would know.
Well, thank you so much. And there'll be more questions. Right now, we're going to enter into a Q&A, and before we have a break. So, and actually, we have well, we have some questions for you, Dr. Wall, but you answered this one. Oh, this is another one, Dr. Wall, from John. Do you also scan the eyes and brain to see if the amyloid is there as well?
Yes, yeah, we do. So we've had one patient with ocular amyloidosis as his major symptom, and so the issue with the peptide is that it's very small, but it's too big to get into the eye and see the amyloid in the vitreous humor. That's a very protected site, and so we have those images, and we will pore over those images and see what we can learn about the binding of any of the peptide around the eye. But the peptide itself cannot get into the vitreous humor, we don't think, and image the amyloid in the eye.
And now that you have permission to re-image people, can we see this in the future being used, maybe not officially yet, but where as a tool to see whether a patient's improving? We were just talking about the fact that we don't yet have an assay of any kind. Could we use your scanning, similar to what they do in the UK, perhaps, to show whether a patient's getting better or their organs are getting better by the fact that they're not lighting up as big an area as they were a year ago?
Yeah, I think one of the things, because I come from an AL background, I think one of the things that we would love to learn is how the amyloid load changes and how that correlates with quality of life. And if the two go together, which we suspect they might, then it would be we would love it to be used as a tool to monitor response to therapy and indeed progression. Lots of people have talked about now there are the availability of multiple drugs for these patients. And so you have the opportunity now to move from one to the other, which wasn't the luxury we had 10 years ago, 5 years ago. And it was the same in the cancer world. Monitoring response to therapy is really important, because if the response is not what you expect, you have an option and you can move on to something else. And that's something that up until now, we've never been able to do for amyloid patients. And so, yes.
Before we move on